So next is Dr. Sampada Kulkarni Irlekar.
I'm presenting on Tisha.
Oh, sorry. Dr. Tisha Vepa Komma.
Yes, thank you. Can I have my slides?
Slides, please.
Thank you. Very good morning, everybody. Okay. Today I will be talking about a retrospective review of consecutive exotropia in a tertiary eye care center. So as we all know, consecutive exotropia is the outward deviation that appears after a primary surgery for esodiation, and the prevalence has been reported between 4 to 29%. While the exact cause is not known, the presence of amblyopia, early surgery for the esotropia, presence of any dissociated deviations, and poor stereopsis are some of the factors that have been implicated, and the procedures that we choose are an MR advancement or an LR recession or both. So the aim of our study was to retrospectively analyze the clinical and surgical profile of the patients with consecutive exotropia and our outcomes. We included all the patients who presented to us with consecutive exotropia and went ahead with the surgery between January 2014 to December 2021. Any patients with any other ocular conditions, any history of trauma, or any neurological conditions were excluded from our study. So our electronic medical records were retrieved, and various data in terms of the history of the patient, examination, intraoperative findings were collected and analyzed against the deviation at post-op day 1 and 5 weeks post-surgery. So we analyzed a total of 46 patients, in which majority were females. We saw that the age at primary surgery was 3 years, a median of 3 years, and the median duration of presentation was 4 years, but there was significant recall bias associated with this demographic. And majority of the patients, 82% of them, underwent a bilateral MR recession for a diagnosis of infantile esotropia. And in the clinical characteristics of the patients presenting with the XT, the preoperative exotropia was a mean of 34 prism diopters with a very wide range of standard deviation, and majority of the patients underwent a unilateral MR advancement. 50% of our patients were amblyopic, and even though the stereopsis was unavailable for 30% of the patients, you can see that only 0.06% had a good stereopsis of 70 to 100 seconds of arc. We had a slipped MR noted in 2 patients, and a pseudotendon was documented only in 10 of the patients with a median of 4 mm, and mean MR advancement performed was 4.7 mm, and mean LR recession was 6 mm. So when we analyzed the factors such as age at first surgery, spherical equivalent, the duration to presentation, and the primary deviation before the surgery for esotropia, we saw that none of these had a statistically significant influence on the outcome, but I would like to discuss the results a little later. So a mean deviation of 16 prism diopters of exotropia was noted, and while success was achieved in 76% of our patients on the first postoperative day, due to postoperative drift, we had it decreased to 47% at the end of 5 weeks. So while we saw that none of these factors such as age at primary ESO deviation and age at primary surgery and the spherical equivalent did not have a significant outcome influence on the outcome, the presence of amblyopia had a weak correlation, and the presence of amblyopia did not affect the amount of exodrift or the outcome. But 75% of the patients who had a deviation more than 40 prism diopters showed the presence of amblyopia. The presence of pseudotendon had a weak positive correlation with the final outcome. And in our patients, post-operatively, orthotopia was targeted and we achieved a dose response of 4.11 prism diopters per mm, except in the cases of the patient who was operated for partial acquired ET, where the patient did well with reduction of the hyperopic correction, and one in which there was a large pseudotendon in which the resection itself corrected the deviation. And this being a retrospective study, influence of stereopsis and suppression could not be analyzed due to insufficient data. A single surgeon has not evaluated and operated on these patients. There was significant recall bias for the duration of exotropia which they presented. And due to postoperative exodrift, we suggest that an augmentation of standard dose for the LR recession, as well as advancing the MR to the original insertion, especially in the presence of dense amblyopia, may give good postoperative outcomes. And maybe we look at a postoperative target of 5 to 10 prism diopters of esophoria. Thank you.
So, how many patients had DVD in your series?
So DVD was, we had about total of 46 patients. DVD was documented in about 6 patients, 6 to 7 patients.
So what was the result in these patients? Because that's very important when you're dealing with, when you're having overcorrections.
Because there was only 6 patients, we did not use it to analyze on the outcomes, but they also were in the group of more than 40 prism diopters of deviation.
DVD is a very important part of the esotropia, particularly infantile esotropia. Sir, question is very pertinent in this.
Yes.
So mainly, most of cases, even they are early, when we do surgery early at the age of 3, and they are manifesting after 4 or 5 sometimes. So sometimes they are the like a not manifested before the surgery.
Correct.
So and how, what literature say about the DVD in the infantile esotropia? It's more than 30%.
What does literature say of the presence of DVD in infantile ET?
Yeah.
Yes, definitely we see DVD in the presence of ET, but when these children were operated, whether it was present or not, we don't have sufficient documentation. And when we, yes.
Yeah. Okay, what they were operated in your institute or elsewhere?
Not all. So that's why one of the demerits is that there is significant recall bias related to both the amount of deviation they were operated for and the age as well as the duration for presentation
No
for
records,
exotropia.
no records.
Some had records, but not as detailed as it would have been if they were from our institute.
But
wherever they were operated in our institute, we had those
but it would
available.
be if you design or study like something, then the all patients are operated in your institute, so data
Is
can
more
be
robust.
analyzed.
Yes,
Yeah.
definitely.
But otherwise, good study, and till now we know by our practical experiences under correction, over corrections, if we do surgery early, only dilemma is that if you do early surgery, then the consecutive exotropia and even manifestation of DVDs in later stage.
Yes, correct.
Yeah.
So we have not found something very significant in our study, but we see that our post-op results are not as great as we are probably thinking they are.
Yeah.
That is all.
Did the amount of MR recession have an effect on conjunctive exotropia?
No, in my study, no. But again, because of the patients, not all were operated from our institute, so the data on that was not as specific. Yes. One patient had MR advancement of 4 point. Okay, so there was one patient in which there was a large pseudotendon documented. So in that, the patient underwent very minimal advancement because the correction of the resection of the pseudotendon itself seemed to have corrected the deviation. I'm a fellow in pediatric ophthalmology. Yes. Axial length, no, but spherical equivalent, yes. No, as part of refraction evaluation, yes, but you're talking about the planning. So, okay. Oh, no. Okay, yes, no, this is not something we look at. Yes. When we're operating for esotropia? So less than 1 year, we measure from the limbus, and more than that, we take standard dosage. Yes. Yes.
Thank you.
Thank you.